After anesthesia and patient positioning, the foot is internally rotated to 20 degrees and adducted to neutral. We do not apply traction as this may close the peritrochanteric space. Fluoroscopy and 17-gauge needles are used to localize our proximal and distal anterolateral portals. The arthroscope is placed in the proximal portal and coblation wand is used in the distal portal to longitudinally incise the IT band for access to the peritrochanteric space. The bursa overlying the greater trochanter is removed with a shaver and coblation wand. Here we can see the gluteal abductor tendons as well as a soft spot underneath the fascia that correlates with our tendon tear. The footprint is debrided using a shaver to expose cancellous bone for tendon healing. Anchors are placed and the sutures pass through the abductor tendons for repair. This is the passing of the rhodium augment after anchor placement. Outside of the body, a suture is passed through a small incision in the rhodium. The rhodium augment is shuttled down to the trochanteric footprint of the abductor tendons, and the repair is performed over top of it. In the rotator cuff repair literature, this has been implicated to increase tendon to bone healing. Next, we move on to acellular dermal allograft application. This is a similar technique to our previous work. The footprint is measured using a calibrated probe and the graft is prepared. Sutures from the anterior superior and posterior superior anchors are passed through the corresponding portions of the graft and mulberry knots are tied. The graft is then folded and shuttled into the peritrochanteric space. This endoscopic video shows the passing of the pre-marked acellular dermal allograft through the cannula by the anchor sutures. Care is taken to mark the epidermal side to ensure the dermal side comes into contact with the tendon surface. After correct placement, the anchor sutures tie down the superior portion of the graft. The final two anchors are placed inferiorly and pass through the graft to secure it. The final construct includes endoscopically repaired gluteal tendons with rhodium wick at the bone-tendon interface and an acellular dermal allograft compressed over the repair. The ultimate goal is to provide structural support and increase healing potential for at-risk gluteal tendon repairs.